Hello, my name is Dustin Anderson. I'm a student in the Doctorate in Athletic Training program at Indiana State University. I work at Fort Sill, Oklahoma with basic training soldiers. Today I'm going to be talking about how I treat ankle sprains, what I think I do well, what I need to improve on, and how I have to treat ankle sprains within the military. All right. First thing I like to do is just have the patient tell me what's going on, what happened, sort of tell me a story of the injury. And one of the things I learned early on is you have to be great at active listening when you're talking to people. And if you look in the corner, there's listen spelled out. And I like this. I think it reflects active listening pretty well. And I'm just going to go through the letters right quick. L equals look interested, get interested. I, involve yourself by responding. S, stay on target. T, test your understanding. E, evaluate the message. N, neutralize yourself, neutralize your feelings. I think that's a great way to look at active listening, and especially when it comes to taking a history with a patient, because you do have to be engaged, you have to be involved, and they got to know that you care, and you got to make sure that you're interpreting what they're saying the right way. If not, you're going to go down the wrong road when it comes to the objective assessment with your evaluation. For me, the evaluation starts before the patient even speaks. Is the patient able to walk in on their own? Do they need help? Are they limping? What's the quality of movement? Is the patient bracing a body part? Are they not wanting to dorsiflex their ankle? Are they not wanting to put any weight on it at all? Are they totally not moving the ankle? What's going on there? And do they look to be in pain? We've all been in pain before, and we've all worked with athletes that you get to the point where you can actually tell if someone's in pain just by their facial expressions. So if they look like they are in pain, more than likely they're in pain. Now, if they're walking up and bracing and there's nothing on their face, either they have a high pain tolerance or the injury might be a little questionable. But again, we don't know until we take the history. For me, it's pretty standard with the history. I want to ask open-ended questions. I want to stay away from leading questions. I want the patient to tell me what's going on. I'm there just to guide them down the roads that I need. So I usually have them tell me what happened. Did you feel anything? If so, what? Have you hurt this area in the past? What's your current pain? What makes it hurt more? What makes it hurt less? And any past injuries. Those are basic questions, but they're also feeder questions for other things that I can ask and other roads that I can go down if I need to. If I don't need to, I'm not going to go down that road with that patient. But again, the take home here is actively listen and make sure that the patient tells you their story. Don't lead them down any road or any path with anything, and make sure that you are taking a good history, because everything else feeds off that. All right, so what can I find? This is just a traditional disease-based approach to what you can find. I hate to say it. I've been in the DAT program for about a year and been trying to work in a patient-centered approach, but I think we're just creatures of habit, and we go back to what's comfortable till we establish new habits with everything. So, comparing everything bilaterally, as far as how it looks, palpations, again, like I said, what's the movement like? This goes with active, passive range of motion. You can have them do functional testing with anything like that. What special tests are positive, and you match up the objective and the subjective sections to get a good clinical look of what's going on. And again, that's just a straight disease-based approach. And when I was doing this and took a good look at what I was doing, I was like, well, I know where I need to be or where I would like to be, but I think that I'm still stuck in this disease-based approach to evaluation. And how it would look if someone comes in for an ankle injury to me, working in the military setting, they have a trauma, acute ankle injury, I follow auto ankle rules. I think that's a great way to triage of who needs an X-ray or who you can keep in house. And you see there in the middle, able to determine. When I first started working as an independent athletic trainer, I was under the assumption or under the notion that every time a patient came in before they left, they had to have an answer. Sometimes the body doesn't want to show you what's going on. And if that's the case, you can crutch them. You can crutch them up for 48 to 72 hours or have them on limited activity, something to let the body calm down so they're not so hypersensitive to pain. Swelling's probably going to be down, and they're going to be a little more calmer, especially if it just happened right then with evaluation. So don't be afraid to say, we're going to let this calm down for a couple of days. They're going to do another evaluation. So if they come in, Ottawa rules are positive, I'm going to refer them to physical therapy for evaluation, possible x-ray. There's not been many times a physical therapist has said, no, I don't think they need an x-ray when I've referred them up for positive Ottawa rules. If the x-ray is positive, they're going to keep them around, and they're going to follow the policies and procedures for stress fracture management. If it's negative, they're going to return them to me, like, hey, nothing was done nothing showed up positive on the x-ray. Evaluate them and plan your course of action. If Ottawa rules come back no, I'm going to conduct an evaluation and develop a plan of care for that patient. Again, I may have to wait a couple days before we start rehab, but I like to take an aggressive approach to rehab. I want to work within their pain limits. I don't think causing a little bit more pain during rehab is bad, as long as their pain level is the same as it was when they came in and they're showing results. And what I like to focus on is pain-free range of motion, strength, neuromuscular control, balance, and a base cardiovascular fitness with everyone. I re-eval every 5 days. If after 14 days there's no improvement, I'm kicking them back to physical therapy, because that's what I have to do with the military setting. I can only put someone on profile or limited activity for 14 days. Then I have to kick them up to physical therapy. And usually they'll look at my notes and be like, yeah, they need more time. They usually follow my recommendations, or they'll be like, hey, we're going to keep them here, we're going to do that, or they'll send instructions back with the patient and they'll do rehab where I'm at. And if everything's going well, after their eval every 5 days, they're improving, continue current course of action until they're ready to be returned to duty. So again, usually within 14 days, people can go back. It gives them a good 2 weeks of learning the exercises and everything else, and tell them how important following that home exercise plan is to being successful, because they usually come in as like, it's 2 weeks, I'm feeling great. I'm like, well, you're still healing. You need to do this for another 2 to 4 weeks before you're fully healed. All right. What I think's missing from my evaluation is that patient-centered care. Patient-rated outcome measures. Does the patient have a disability? Using disablement models to drive clinical practice, and patient satisfaction of care. We all like to think we do a good job, but we don't know if we're doing a good job till we ask our patients. And a better job of tracking the injuries that are going on. I think if I had a better understanding of common injuries, where they happen and everything, I could become better in developing injury prevention strategies and seeing if they actually work. So how I think my evaluation is now is to ensure that the patient at minimum is able to return to a normal level of functioning before returning to physical activity. The shift that I want to see myself make, and I think we should all make, is to ensure that the patient's health, quality of life is minimally affected by their injury. And I think that goes back to what we've been learning is a patient-centered approach driven by PROMs, health quality of life, and patient-rated outcomes with everything. I think that's the future and where I'd like to see my clinical practice go. It's just going to take some time to change those habits and to get into new ones. But I think that if I ensure that the patient's health quality of life is minimally affected, I think I've done my job. Thank you for your time.